Welcome to the About the Face podcast, sponsored by the American Academy of Facial Plastic and Reconstructive Surgery through the Facial Plastic Surgery and Aesthetic Medicine Journal.
Hi, my name is Matt Miller. I'm senior author of our recent research paper published in Facial Plastic Surgery and Aesthetic Medicine, exploring disparities in facial reanimation surgery. I direct the Facial Nerve Center at the University of North Carolina. So, why did we choose to explore this topic of disparities in facial reanimation surgery? Most people by now appreciate the devastating effects facial paralysis can have on both the physical and psychosocial health of patients affected with this disorder. And while certainly not perfect, our understanding of facial paralysis and our facial reanimation treatment outcomes have really improved the last decade or so. However, while facial paralysis affects all races and cultures without preference, recent research suggests that Black patients, patients living in rural areas, and patients with Medicaid or no health insurance are less likely to undergo facial reanimation surgery. And so with this research, we wanted to understand this known treatment disparity better. Specifically, do these underrepresented patient populations elect to undergo facial reanimation surgery at a lower rate than white patients and patients living in metropolitan regions? Or do these underrepresented populations have less access to care, preventing them from being evaluated by facial reanimation experts? So is it an access to care issue, or is it a motivation to treatment issue? That is what we wanted to understand better with this research. We hypothesized that decreased access to care is the primary reason that certain communities have lower rates of facial reanimation surgery. So how do we study this question? Well, our Facial Nerve Center at the University of North Carolina treats patients from all over the world. Being the state hospital, most patients do come from the state of North Carolina. And North Carolina is an incredibly diverse state with regard to all levels of diversity. For example, while 60% of North Carolinians live in urban areas, the state still has the second largest rural population in the country. Minority racial and ethnic populations now comprise about 40% of the state's population, and there's also tremendous socioeconomic diversity. And so we compared our facial nerve center's population to that of the states to evaluate whether certain population groups are less likely to present for evaluation. Then we explored whether any of these demographic variables studied correlated with the decisions by patients to undergo facial reanimation surgery once they presented to the Facial Nerve Center. So what did we find? We studied almost 600 patients who presented to our Facial Nerve Center over the last 2.5 years. Numerous facial paralysis etiologies were included in this research, as was the entire spectrum of facial paralysis severity. So some patients had mild facial paralysis as graded by clinicians, while other patients had severe facial paralysis as graded by clinicians. We found that Black patients, males, non-English speaking patients, and patients from non-metropolitan areas were significantly less likely to present for facial paralysis evaluation. For example, while only about 60% of North Carolinians live in urban communities, almost 80% of our Facial Nerve Center's patient population comes from urban areas. Another example, only 36 patients presented for evaluation to our center who did not speak English, that's only half the number we would expect based on the non-English speaking population in the state of North Carolina. However, once patients presented for evaluation to our Facial Nerve Center, we found that there was no association between demographic variables studied and whether patients decided to undergo facial reanimation surgery. So how do we wrap this all up? What do these findings mean? We show that treatment disparities are related to access to care and not to patient motivation to treatment. Our research is the first step toward better understanding facial paralysis treatment disparities. However, it is only a first step. Future research should use qualitative methods, patient interviews, talking to patients, to identify why patients in certain communities do not seek care. Do they not know treatment is possible? Is it too far of a drive to receive quality care? Do they think health insurance will not cover treatment? As a surgeon who spends almost every day of the week talking to patients with facial paralysis, these are themes that I hear all the time. Worried about insurance not covering treatment. It's too far of a drive. It was too long of a wait. I didn't know anything was possible. Once we have developed a more thorough understanding of why this differential access to care exists for facial paralysis treatments, we can then implement strategies to try and reduce these disparities. And this is really what we need to do. We really need to identify and implement these strategies to reduce treatment disparities so that all facial paralysis patients can receive the care they deserve. Thank you very much for listening today and for reading our research in facial plastic surgery and aesthetic medicine.
We'd like to thank the authors for their commentary and thank you for listening to our podcast. If you'd like to explore more, please feel free to check out the article in print at the Facial Plastic Surgery and Aesthetic Medicine Journal or online. We'll catch you on the next one.